This is the lunch symposium on inspiration and installation. Is it an innovation? The promise of VAC installation therapy. And for this, we have Dr. Paul Kim from Georgetown, who's going to talk about our recent experience with the product. We have one of the world experts in infectious disease who's going to talk about the potential of installates on bacteria. Lawrence Lavery, unfortunately, was unable to come, and so his talk will be included in Dr. Kim's talk. My job is a setup guy, and that's what we're going to do. So first slide, please. So, do I click? Is that the story? So this is true installation therapy in the Serengeti, how to get rid of ticks, etc. But what we're going to deal with is a much more serious problem, is infected wounds. There we go. So I'm an unpaid consultant for KCI and try to stay unbiased on this, although it's always questionable. So I'm going to discuss the role and potential shortcomings of negative pressure wound therapy in wounds and what adding installation brings to the table. And then I'm going to discuss some of the early literature that made us all think that this might be a solution to a very difficult problem. So as you all know, and many of you have used it for years, negative pressure works by decreasing edema, increasing local blood flow, speeding up the formation of granulation tissue, and decreasing the bacterial count. And indeed, it's used in every aspect of reconstruction, including preparing a wound for closure, using it as a incisional device to hold the wound together postoperatively, using it for skin grafts, for vascularization of dermal matrices, for flaps and flaps that are in questionable state. The key here is that negative pressure should only be used on clean wounds. Often it is not, and that's when things go awry, and you should put it in such a way that you avoid maceration. The problem with negative pressure is that you do not get rid of all the bacteria. At best, you get down to maybe 10 to the 4 log. Remember, 10 to the 5 log is something that's been used by plastic surgeons as being the most amount of bacteria that will be tolerated on a wound for a skin graft to take. How good a criteria that is or not is questionable, but everybody uses that 10 to the 5 as an index of whether a wound is clean enough to close. So retrospective studies and prospective studies show that irrespective of what you do, you never get below that 10 to the 4 level with negative pressure. And indeed, when you look at your own wounds, you realize that when you do a negative pressure wound therapy dressing change, it often stinks. Sponge material can be left in the wound when you remove it. In a randomized study done by Armstrong, there was a 17% infection rate in the negative pressure group. This might be a reflection of the inability to be able to get rid of all the biofilm, which we'll discuss. And it may require redebridement, longer length of stay in the hospital, and more operations per wound because the wound is not as ready as you thought it was. So biofilm, you've heard about increasingly at these meetings over the last 5 years. You need to realize that what we culture is not a biofilm, but it's the bacteria that are free-floating, ready to form new colonies. 99% of the bacteria do live in these aggregates in a glucose-type matrix where they behave at a much lower energy state and much like a society with each having tasks to do, and they share cross-sensitivities to antibiotics. Here's what biofilm looks like under a plate that was removed. You can see the slime. It's the same thing when you walk across a pond and you slip on a rock, that slime, or when you feel your teeth in the morning when you wake up and you feel that slime, that's what it is. This is what it looks like under high magnification. And remember that the more diverse the population, the more difficult it is to get rid of. One of the real challenges for us dealing in the foot is that you could get rid of it by debriding radically. The problem is that the biofilm can penetrate up to 4 millimeters below the depth of the wound, along the vessels that feed the depth of the wound in a process called perivascular cuffing. So 4 millimeters is a lot when you're dealing with the dorsum of the foot, and if you get rid of it, you're on bone, tendon, or artery or vein before you know it. So how do you get rid of it? Well, you can get rid of it surgically, but I just showed you that it's limited in its success because you have to go a certain depth to get rid of it, and then you may not have a foot left. So there are ways that they've tried to dissolve the biofilm so it can be gotten rid of, and there are also mechanical ways to get rid of it by cracking it. Negative pressure is one such tool that it does, has been shown to crack the biofilm. And so the thought was that by introducing instillation therapy or bathing the cracked biofilm in a cyclical fashion, you might be able to have better results than just using negative pressure without instillation. And indeed, the fruit for that is Fleischmann's pivotal study in 1998, where he looked at 27 wounds, 8 with osteomyelitis, 13 with chronic soft tissue infection, and 6 with chronic wounds, where he used an antiseptic for 30 minutes several times a day for 7 days. And he closed all the wounds, and all of them healed within 4 months with only 1 recurrent osteomyelitis. Subsequently, Gabriel did a study using silver nitrate, which is used in burns. It's very, very unstable, and so it has to be used with tubing wrapped in silver, and it's only the 30-second installation time with a 1-second dwell time. But the results were really pretty spectacular. A third of the treatment days, a third of the infection rate, half the time to close, and all the wounds closed using that therapy. The problem, it's quite difficult to use. This consecutive case of infected wounds done by Schindler showed that he was able to close 100% of the wounds using the antiseptic polyhexanide. More interesting is this prospective study done with cohort control, where they had 30 patients who had osteomyelitis, and they either treated them with instillation therapy and antiseptic versus the traditional IV antibiotics and antibiotic beads. And they used 15-minute dwell time. They averaged treatment for 22.4 days, and with an average of 2 weeks of antibiotics. And amazingly enough, the group with instillation therapy had 1/6 of the recurrence rate, had half the hospital stay, had half the hospital admissions, and had less than half of the operations needed. So clearly, there is something to this therapy. More interesting is a very difficult problem that orthopedists face when they treat total joints. And this was Lehner's work with total hip infections, in which he looked at 23 patients, 19 of which had infections 8 weeks within the 8 weeks postoperatively, and 4 had them after that 8-week period. And they used, again, the antiseptic polyhexanide, and they found that they were able to retain 16 out of 19 joints by just removing the plastic component, irrigating, and then replacing it with a clean plastic component. And in the late joint infections, they were able to save half of them. So pretty interesting. That prompted them to do a multicenter prospective study where they used polyhexanide. They had 32 patients, with 22 had acute joint infections and 10 chronic. And they used, again, polyhexanide as an antiseptic. And their results showed that they were able to save, in the acute patients, 86.4% versus controls 65%. And in the chronic, that means more than 8 weeks, they were still able to save 80% versus 30% of the controls. So this all shows that there is something to this negative pressure with instillation therapy. So we obviously need randomized prospective studies, of which there are none. We're currently heading a group to conduct that. We have to look at the quantitative cultures and PCR data to see exactly what instillation therapy does. We don't know what the best instillate is. We don't know what the best dwell time is. We don't know what the best cycling is. And we also need long-term data to see if this clearance of infection holds up over time. So negative pressure with instillation therapy shows promise, better control of bacterial log counts on the wound. It may have an effect on biofilm by cracking it and then allowing whatever instillate to bathe the wound. It may decrease hospital days. It may decrease numbers of surgical operations to get a wound healed, and it may decrease recurrent infection. So with that introduction, I'm going to turn over the podium to Dr. Lipsky, who's going to discuss the role of instillates on bacteria. Dr. Lipsky.
Great start, Chris. Thanks very much. Thanks for inviting me to be part of this symposium. So Chris asked me to speak on the role of topical antimicrobials in negative pressure wound instillation therapy for diabetic foot infections. I've had an interest in topical treatment for a couple of decades, actually, and I think that's why Chris was interested in hearing my thoughts on this. In terms of disclosures, I've been a member of the Infection Control Board for KCI for 3 years and have served as a consultant to KCI. I spent a couple of days out there last year looking at their facilities and learning more about how they developed some of the products that we're talking about today. What are the reasons to consider topical antimicrobial therapy for mildly infected wounds? Well, wound infections, of course, cause a variety of problems. They start with discomfort for the patient, and that's why the patient usually comes to see us. They may have drainage and odor. They may delay wound healing, even if the infection itself is not very severe. And of course, infection can then progress contiguously to deeper tissues, including into bones and joint. There are a number of mechanisms by which organisms cause microbial toxicity. They produce an inflammatory mediators, metabolic wastes. They cause an activated state for polymorphonucleoleucocytes, which produce cytolytic enzymes. And of course, they compete with the host cells for nutrients and oxygen. So there are therefore potential advantages to antimicrobial therapy applied topically, and I've listed a number of them here, and I won't go into any of them in great detail, but you can certainly get very high concentrations of applied agents at the site of the wound, and especially if you're using antibiotics that are concentration dependent, for example, gentamicin, getting very high levels allows it to be effective against organisms that might otherwise appear to be resistant based upon the achievable serum levels of those agents and the MICs of the organisms. You only need a limited amount of antimicrobials, and we know that the total tonnage of antibiotics used is related to the development of resistance. So the smaller the amount of antimicrobial, the better. There's limited potential for systemic absorption and toxicity. We know that various antimicrobial agents can cause kidney problems or other problems. Low doses reduce that risk. There's a reduced need for using systemic antibiotics and therefore hopefully reduce in resistance problems. It's fairly easy to apply topical agents, and it may be that patients adhere to topical therapy better than they do with systemic therapy. And I think an important issue is that it redirects the patient's attention and the provider's attention to the wound. Let me give you an example of what I mean by that. So here's Dr. A, and Dr. A is talking to the patient about this foot ulcer that he has that's infected, and he's got a bottle of pills in his hand and he's explaining to the patient how to take these pills. And I think of this as sort of mouth to mouth to mouth, talking and pills. Here's a much better doctor. Dr. B is down there at the patient's foot. The patient's now looking at the foot, so he's involved with it, and we're talking about putting on this topical agent. And I think that the fact that the patient has to look at their foot and has to assess what's going on when they're putting on the topical therapy actually is a substantial potential advantage of topical therapies. Now, of course, there are potential disadvantages as well. To list those, there are a few agents that have been proven to be effective in clinical trials. There's minimal penetration of these agents to intact skin, so you get pretty good levels right in the open wound, but it doesn't penetrate out into the intact skin of the surrounding cellulitis. There may be some systemic absorption if the wound is large and you're using large amounts of the agent. There's a possible alteration of normal cutaneous flora that occurs. It's difficult to accurately dose the agent. Frequent reapplications may be needed. It may be difficult to apply or aesthetically unacceptable to the patient. It can become contaminated if you use the same tube over and over again and the patient takes his hand, touches the wound, and then touches the tube to get some of the cream. It may cause local hypersensitivity reactions, and it may interfere with the wound healing process. So this is a key issue. Alexander Fleming, back in 1919, 10 years before he published his first paper on penicillin, actually said it's necessary in the estimation of the value of an antiseptic to study its effects on the tissues rather than on the effects of the bacteria. And so we have to be aware that topical agents do have potential toxicities. They're generally safe for intact skin and have potentially useful antibacterial and desloughing actions, but most agents do show some toxicity to host cells. They prolong the acute inflammatory response, they delay production of collagen, and they can be toxic to human fibroblasts. Studies, however, suggest that the cytotoxicity that we see in vitro tends not to be as severe when we look at in vivo open wound models. There are a variety of other adverse effects that can occur, including delayed hypersensitivity, superinfection, and selection of resistant organisms. What kinds of topical antimicrobials are there? We start with disinfectants. These are non-selective agents that kill or remove microorganisms on inert surfaces. So they're the kind of things that you spray on your counter in your kitchen to kill all the bacteria. Then there are antiseptics, which is a form of disinfectant that can be used on intact skin and some open wounds to kill or inhibit microorganisms. These often work by multiple targets, and in that respect, they differ from antibiotics, which are chemicals that initially were produced exclusively by other microorganisms, but now can be produced synthetically or semi-synthetically. And in dilute solutions, these inhibit or kill microorganisms, but usually by targeting one specific mechanism within the bacterial cell. What available agents are there for topical antimicrobial use? Well, you can see there's a whole list of antiseptics and a whole list of antibiotics. And I won't go into any detail, but just to show you that there are many potential agents that could be used. Unfortunately, few of these have been studied. The role of topical antimicrobials in diabetic foot wounds can be summarized as follows. There's little support for clinical utility of these agents in clinically uninfected wounds. So if you think putting them on an uninfected wound will either reduce the likelihood of that wound becoming infected or accelerate healing by reducing the wound bioburden, you don't have any proof to support such a belief. Now, how about for critically colonized wounds? So for those people who believe in colony counts being important in determining whether or not a wound will heal, is there any evidence for efficacy of using topical antimicrobials to reduce the colony counts? There's a little but not very supportive evidence, and on the whole, most people who have looked at the data have come to the conclusion that we really can't support using topical antimicrobials for this purpose. Well, what about infected wounds, wounds that present with signs of inflammation or purulence? Well, they certainly can work for primary superficial pyodermas like impetigo. We know that putting a topical antimicrobial cream like mupirocin on a group A strep infection like impetigo works quite well. And they may also work for mild ulcer infections. There's at least one published study of an antimicrobial peptide, pexaganin, that demonstrated that it was equally effective as an oral fluoroquinolone agent. So there's some hope that this may be useful, but we need further studies of that. It can be used as adjunctive treatment with systemic antibiotics, but we don't know whether that works. But this is currently under investigation. In Geneva, we're doing a study looking at the addition of a gentamicin collagen sponge to systemic antibiotic therapy with patients who have moderate to severe infections to see if it adds something. That's a superiority trial. We're looking for new agents, though, and what we'd really like is new agents that have immune modulatory and anti-biofilm effects. You heard beautifully from Chris about the importance of biofilm and the fact that we need to try to figure out ways to get rid of it to help infected wounds to get better. Now let's move specifically to the issue of instillation therapy of topical solutions and related to diabetic foot wounds. Obviously, all wounds quickly become colonized with microorganisms, and there's two types of microorganisms that are there initially. Resident flora, such as coag-negative staph and corynebacteria, which are there all the time and are virtually impossible to remove. And then transient flora, which come from the environment, colonize the wound, and can be removed in one of several ways. And that includes Staph aureus, some gram-negatives, and occasionally enterococci. These organisms, of course, can grow to high concentrations, and they can predispose to failure of the wound to heal, or they can initiate clinical infection, as we've referred to before. So the idea is that topical therapy may reduce the wound bioburden or treat the superficial infection while avoiding some of the problems associated with systemic antibiotic therapy. And we have a long history of wound irrigation being quite helpful in helping wounds to heal. Now, when we look specifically at the issue of what installates are there available for use with negative pressure wound therapy, again, there are a list of antiseptics. If you go through the literature, you can see that people have used one or more of these agents. There are a list of a few antibiotics that have been used, in particular the sulfonamides, and other agents like saline and dilute lidocaine. The lidocaine, of course, used for patients who have painful wounds. What's the evidence that you can actually reduce bacterial bioburden when you put in Instillate with antimicrobial activity? Well, a paper that was just published last month makes a very nice point of the drop on day 0 shown in the light aqua color and day 7 shown in the darker blue color. On the left side, you can see that negative pressure wound therapy with Instillation, there was a statistically significant and dramatic drop in the number of organisms in the wound as compared to just negative pressure alone, where there was not only not a drop, but a non-significant increase in the number of organisms. So certainly suggests that you can knock down the wound bioburden if that turns out to be a helpful thing to do, and we think there's certainly suggestive evidence that it does. Now, one thing I think is important to talk about, we've been talking about antimicrobials, whether they be antiseptics or antibiotics, but there have been a number of studies using just plain old saline, and a very recent study out of France, Luc Thiau's group, looked at saline instillation. They did what they called a prospective clinical study to study saline instillation as adjunctive treatment for wounds currently or at high risk of becoming infected and that were not responding to conventional therapy. At 3 centers in France, they enrolled 131 patients with a variety of wounds, 13% of which were diabetic foot ulcers. All of the patients underwent appropriate surgical treatment, mostly debridement, and then they received systemic antibiotics that were based upon the results of tissue cultures. They had a mean duration of instillation therapy of 12 to 19 days. And in 98% of the cases, the wound was able to be closed by either primary suturing, skin graft, or a wound flap, suggesting that this saline therapy was fairly effective considering that it was being used on wounds that had not been responding to other forms of therapy. So a certainly positively suggestive study here. Now, a group of people got together at a wound therapy installation international consensus conference and came up with a set of guidelines. You can see the 13 people who were at the conference, and Paul Kim and Chris Attinger were the lead people in that conference. And I just want to present to you a few of the top-line consensus guideline conclusions that they came to. This expert panel decided to not directly address the clinical effectiveness of instillation therapy because there were just too few data for them to make any conclusive statements about that, but they were able to make a few useful statements. The first was that that instillation therapy appeared to be a useful adjunct after appropriate evaluation and treatment of various types of wounds. Secondly, it doesn't replace debridement of colonized or infected wounds. Instillation solutions include a variety of agents, particularly polyhexanide and microsendermicin, and I'll come back to that in a moment. The appropriate installation dwell time, volume, and pressure that you could use were decided upon and shown in this slide. And finally, the duration of therapy varied from at least 1 day to not forever, but basically they suggested that you should use instillation until the wound was ready for the next phase of treatment. Now, they also looked at each of the available agents and got people to vote through a very interesting Delphi technique and another statistical method. And they kept sending out the results to people until they came to a consensus. And you can see that I've listed the names of the various agents that they looked at, and at the far right, whether or not they ultimately came to consensus that there was sufficient evidence that this was an appropriate agent to use as an installate. There were only 3 that got a yes vote: polyhexanide, Prontosan, which is a combination of polyhexanide and betadiene, and microsindermicin, which is a hypochlorite sodium or hypochlorous acid solution. So those are the 3 that they felt there was reasonable data for. So what are my conclusions about the installation of agents for negative pressure wound therapy? I think it's a promising new treatment modality for selected wounds that are or are likely to become infected. But of course, like we always say, we need more well-designed controlled trials. There just aren't any available currently, and I'm looking forward to the results of the one that is currently being done by Chris and Paul at Georgetown. We particularly want to know what types of wounds would most benefit from this therapy. What specific solutions should we use for installation, and certainly comparing antiseptics versus antibiotics and looking at antibiofilm agents? How long a treatment duration is most appropriate? But meanwhile, I think it's reasonable to say that we should avoid using antibiotics for installation to avoid worsening the current crisis in antibiotic resistance. And unless something proves better than plain old saline, it seems to me that that's the most reasonable thing that we ought to be using, although I suspect that when compared to head-to-head, we may find that other agents work somewhat better. So the promise of topical therapy, I think we hold out a lot of promise to our patients about various kinds of topical agents, but I think if you give them the idea that they'll start out as a before and an after, then they may be a bit disappointed with the results. Thanks very much for your attention.
And to finish is Paul King from Georgetown. Paul?
Thank you. All right. I'm going to talk about our single institution experience with negative pressure with installation. We were first approached about this therapy in 2011, and since then it's become our standard of care, and we've applied this therapy for over 1,000 patients. We started to collect some data retrospectively, and there's some prospective data as well that I'm going to present today for the first time, comparing directly Prontosan versus Saline. So first, here are my disclosures. I have received both research and consulting funding from KCI. Let's talk about effectiveness. This is high external validity, low internal validity types of studies. This is the first study that we published. This is the most robust study yet published on installation. Just came out in PRS last month. And we had, originally last year, we had presented some preliminary data that I had sampled out of this and presented it. It was intriguing, it was interesting. We can continue to look at that, and now it's in print. So let's look at the methodology for the study. Number one, this is a retrospective study, and we analyzed consecutive patients with a historical control of standard negative pressure. We gathered data from inpatient charts from a single institution. There were 4 surgeons involved. There were 142 patients who received the old InfoVac, which is a traditional negative pressure, compared with the Ulta therapy, which is the installation therapy. Again, the same time period, but 1 year spaced apart. And that was important to establish that our other techniques that we used during this time of data collection had not changed. So as far as the device, the negative pressure, we used, again, the Ulta VeriFlow system at -125 continuous. And we looked at 2 different periods of negative pressure, just negative pressure, 3.5 hours versus 2 hours. And as far as installation, we used Prontosan, which has polyhexanide, which is an antiseptic, and betaine, which is a surfactant. We looked at 2 different soak times. So this was sort of a dose-response study as well. As far as the volume of the installation we just used enough installation until the sponge was visibly saturated. Other methods, the admission criteria, all these patients had confirmed infection and admission to the hospital. As far as discharge criteria from the hospital, they had to clear the infection, whether it was confirmed by decreasing white blood cell counts and/or qualitative cultures. So surgical technique, we were all trained under Chris Attinger, so we all used the same debridement, radical excisional debridement in the operating room. We also irrigated with 3 liters of normal saline with no antibiotics in the normal saline during irrigation in the OR. The independent variables we looked at were culture changes between the post-debridement cultures of the first OR visit and the pre-debridement cultures of the second OR visit. We looked at the number of OR visits in total, length of hospital stay, percent closed prior to discharge, number of days to closure, and we also looked at qualitative cultures. We took cultures from the deepest margin of the wound or infected site, then we converted these qualitative cultures that you probably see in your hospitals to a nominal data so that we can analyze it. If they were polymicrobial, we averaged them for each patient, and we had an average number that we compared. Here are the demographics of these patients. The important thing is looking at these 3 columns. The first on the top left there, NPWT is standard negative pressure. The second column is negative pressure with instillation with a 6-minute dwell time. That's the 6. And the last column is negative pressure with instillation with 20 minutes of dwell. And as far as the demographics are concerned, these descriptive statistics, there was no difference in our patient populations. One thing I want to point out, really, if you look at the comorbidities, these are very sick patients that we treat. The majority have some sort of diabetes, type 1 or type 2, with end-stage renal disease and peripheral vascular disease. So these are very challenged populations that we took care of. As far as the wound cause and anatomical location, we included all comers. This is why this is an effectiveness study rather than an efficacy study. We looked at ischemic wounds, neuropathic, decubitus, surgical, venous, traumatic, and unclear wound etiologies. As far as the anatomical location, we are a limb salvage center. However, we do other parts of the body as well, including the back and the buttock and the abdomen and the upper extremities. And statistically, these were all similar groups. Here are the results. The number of OR visits for both the 6 and 20-minute dwell were statistically significantly different than the standard negative pressure, meaning they had fewer trips to the operating room. As far as length of stay, for the 20-minute dwell time, we reduced the length of hospital stay by 3 days. Time to surgical procedure for both the 6 and 20-minute dwell were reduced by 2 visits to the, 2 days. As far as the percent of wounds closed prior to discharge, this was significantly different. 94% were closed prior to discharge from our hospital. And as far as the overall culture results, there were some, right before that, as far as the wounds after 1 month out in the clinic, because perhaps you're thinking, well, you guys closed more of these wounds because you were biased toward the instillation therapy. So I looked at this data 30 days out, meaning they were discharged from the hospital, they came back to our clinic, and looked at those numbers, and they were not different from our standard negative pressure. So I inferred from that, we did not close them prematurely. As far as the culture improvement, if you excluded gram-negative bacteria, Corynebacterium, and yeast, there was a significant improvement in the qualitative cultures for the 6-minute dwell time. Study limitations are obvious. This is not prospective or randomized. We use historical controls. We use qualitative cultures, which are not the best way to look at bacteria. These are non-standardized volume of instillate used, and the length of stay of hospital stay variables weren't accounted for because they may have been there for longer for some other reason and not for the wound. And this is why we wanted to make sure we looked at how long it took for that patient to get their final procedure done as one of our endpoints rather than looking at the length of stay, although the length of stay was also significant. Now let's look at efficacy data. These are, if you know about effectiveness versus efficacy, are more tightly controlled, and in a randomized fashion, these are probably the better types of studies to do. Well, based on our retrospective study, we are participating in a large multi-center study, prospective randomized, 6 academic institutions, 200 patients. We're looking at similar variables as our retrospective study, but we added some additional variables including pain, quantitative cultures, adverse events including readmissions and infections. And currently in that trial, there's approximately 50 patients enrolled in that trial, and we're hopeful by the end of fall or early winter we'll have that study complete. And I know that Dr. Lipsky talked about installation solution, but it sort of leads us to the next study that we're currently doing at Georgetown. This is the porcine explant study by Greg Schultz. And I think what's interesting here is if you look at the saline group, it doesn't look like it's any different than the untreated group or the standard negative pressure group. But if you look at the polyhexanide, you see a significant reduction in colony-forming units, which would indicate that perhaps polyhexanide works better than saline. However, if you look at this study published by Lavery, this is a slightly different model. The control did not, these are swine model, these are not explant model, these were wounded, and then they were inoculated with Pseudomonas, which is a very difficult bug to eradicate. And what we looked at is colony-forming unit reduction using this model. If you look at the control group, obviously that's your no change group, and then standard negative pressure, and you looked at saline, it looks like there was a significant drop with saline, but also with polyhexanide. So this is a little bit confusing based on Schultz's data, which showed that there's really no reduction using saline. So this really got us thinking and scratching our head and seeing if we can better define this. I know that, again, Dr. Lipsky has already presented Luke Tiot's data. What I think is interesting about this, although he described the etiology and using negative pressure before and after the instillation therapy, there's really no bacterial commentary in this study, although it sort of alludes to the idea of reducing infection using normal saline with instillation. They don't really report any bacterial counts at all. What's impressive, though, is the wound closure rate was fairly high, which is what we found with our retrospective study. If you look at polyhexanide, I know Chris had talked about this a little earlier about Burkhard Lehner's orthopedic salvage rate. He did report the bacterial counts, so we can at least assume that these were infected. And what was very impressive is the hardware retention, or the total joint implant retention, that they were able to achieve in that study. So based on those studies, we felt that we needed to take it a step further and look at the two solutions. I know there's lots of questions about this therapy, but one of the pivotal questions in my mind is, what type of insulate are we supposed to use? So we designed a prospective randomized comparative effectiveness trial comparing Prontosan versus normal saline. And we were projected to enroll 100 subjects, 50 in each group. And these were all patients admitted for an infected wound, just like our retrospective study. And I'm going to present the preliminary data today, and you're the first to see it. Now, again, this is the preliminary data. This is sampling of the first 25 patients that we had in this study. So it's important to realize that this is early and it could change. However, what I found was this is almost exactly how I analyzed the data for our retrospective study, and it turned out that retrospective study, it played out. And the same thing we saw in our small sample, we saw in our larger, robust study. But keep in mind, this is all preliminary data. Again, the device is negative pressure of 2 hours, an instillation solution of polyhexanide or normal saline. Although, as you all know, there's a shortage of normal saline right now, so that was somewhat of a challenge. And then we did a 20-minute dwell time. And again, the volume of instillate that we used is until that sponge was visibly saturated. Methods, again, the same admission criteria, same discharge criteria, same surgical technique that we used in our retrospective study. Now, these are the demographics. Don't worry about the last column, because these end sizes are so small, they're really meaningless. But basically, it just tells you that the demographics are about the same. These are two populations of patients that are about the same. And this also includes their comorbidities. We still see very sick people, diabetics with peripheral vascular disease. As far as the wound etiology, it varied just like our retrospective study. And wound location, we are again a limb salvage service, so most of it is in the lower extremity. However, we did look at other parts of the body as well. And here are our results. And again, the statistics I don't want you guys to focus on. But what's interesting in the number of OR visits, which is that first row, these are consistent with what we found in our retrospective study. So it sort of validated that there is a reduction of OR visits for using either normal saline or Prontosan. However, there was no difference between normal saline and Prontosan. That was the interesting thing that we found early on. And this is also true of length of stay. There doesn't seem to be any statistical significance. Again, this is a small sample between normal saline and the Prontosan group. This is also true of the time to final surgical procedure and the percent closed and the percent that remain closed. So what does this tell us? It tells us that, one, that normal saline and Prontosan don't seem to make a difference in these surrogate outcomes that we used in our retrospective study. We're a limb salvage service, so we're less interested in percent rate rate of wound healing or percent of those wounds that close eventually. Remember, this is in the acute setting in the hospital. So these surrogates sort of tell us the installation solution, one, works, and secondly, we're not sure that there's a difference between an antiseptic solution and normal saline. The study interpretation, too early, grossly underpowered for any definitive conclusions, and there's huge beta error that could be occurring right now that we're not picking up a signal when there actually is one. Two, these are qualitative culture data I didn't even include, and this is something I need to speak with Dr. Lipsky about, but they were nonsensical. Cultures were improving, they were decreasing, they were increasing. I couldn't make any sense of it, especially with the small sample that we have. The signal may be too weak to detect. Perhaps there is a difference between normal saline and Prontosan, but we just can't detect it with the way that we're looking at it through these surrogate endpoints. But there are possible trends that can be identified. If this plays out like our retrospective study, this sort of turns, it really upsets the cart, if you will, that a normal saline, which is cheap, easily accessible, readily accessible in all hospitals, may be a better solution than the more expensive antiseptics that are available. So the conclusions, one, early evidence equals negative pressure therapy with instillation has clinical utility. Number two, however, this is the caveat, too early to make any conclusions on efficacy or effectiveness. I don't think we really will know or make any real conclusive statements until our randomized controlled prospective multicenter study, until we analyze that data and take a look at that. I will warn you, though, that randomized control prospective multicenter study, we used Prontosan. We did not use saline. So that study, perhaps our normal saline versus Prontosan study would answer that question. Thank you.
Thank you, Paul. I have a question for the two panel members. Obviously, in looking at the saline study versus Prontosan, it brings to mind the mechanics of decreasing bacterial count and stimulating healing. With an antiseptic, you're killing bacteria. With saline, you're just flushing out the system. So the two instillates have completely different modes of therapy, and I'd like you to comment on what you think might be going on.
Well, first I want to thank Paul for having the courage to present some preliminary results, and I hadn't seen them or heard about them before, so having said in my closing conclusions that unless something is proven to be better than saline, we should be looking at saline, and so I'm actually interested and enthusiastic about at least your very preliminary data. To try to address Chris's question and to try to potentially address very preliminarily your question about what's going on with the cultures, there's lots and lots of bugs in wounds, and now that we use molecular microbiological techniques, we find out that it's a far more complicated situation than we had ever appreciated before. There are organisms that we didn't know were there, and there are many more total organisms, particularly anaerobic organisms, than we knew were present before we had the molecular techniques to show them. When you put an antimicrobial in the wound and then you take some of the wound fluid out and culture it, you're going to have some residual effects of the antimicrobial, and what grows or doesn't grow on a standard culture plate is going to be affected by that residual. There's been debate for hundreds of years probably about, well, at least 100, about the value of getting rid of bugs versus keeping bugs. You probably may remember from your school days the term laudable pus, and you'd wonder why would any surgeon think it was a good thing when pus came out of a wound. And it turns out that wasn't as crazy as it sounded. The presence of Staph aureus tended to accelerate wound healing in some patients, and that's been shown in a number of studies since that time. So certain organisms seem to trigger a healing response, and their presence may not be harmful, in fact, may even be beneficial. So I think there are a whole variety of things that may be going on to make it difficult to interpret what's going on, and I'd be very interested to sit down with Paul and look at your culture data.
Any questions from the audience?
While people are thinking, Paul, is your study's not blinded, is it?
It is blinded as far as the surgeon does not have a choice whether the patient gets normal saline or Prontosan. Our fellow will tell them after opening an envelope that says this patient's going to get normal saline or Prontosan.
So it's concealed, but it's not blinded.
That's correct.
The person who's making the determination of the clinical outcome is not blinded to what the patient's on.
That is correct.
Okay.
But I will say that we're guided by the cultures, and we do not close if the cultures are not negative. So we use the same criteria to guide our closure of the wound, irrespective of what was used as an installation.
So for better or for worse, you have an objective criteria. We just don't know if that's the right criterion. Yeah.
Correct. Anyone else have any experience with, sir, please?
Thank you very much. Dr. Kim, where do you decide now to use this particular technique, and what particular cases do you not use this technique?
Well, we're pretty liberal with it now that we've been using it for so long that really everybody would get installation therapy, whether right now currently, as far as the study is concerned, if the patient is agreeable to enroll in the study, then they'll get randomized into those two groups. If, for example, the patient says, I don't want to participate in a clinical study, then typically we still fall back on using Prontosan as our instillate, and we use installation therapy. I think it's important to point out we're a surgical service, so all of these people get excisional, pretty radical debridement prior to applying anything. And I'm not sure I would recommend using this in any other setting prior to doing a very thorough, sterile, OR-based debridement technique.
Yeah, this is not outpatient-based. This is hospital-based, and it's perisurgical.
I have a question for Dr. Lipsky. I was very hopeful that, maybe this is my bias, I was very hopeful that the antiseptic would work, because it seemed to me a logical thing to conclude that normal saline would do nothing or perhaps make the wound worse, which is not what we're finding, at least preliminarily. What do you think about the growing role of antiseptics versus using antibiotics? That's one of the things you said do not use is an antibiotic in the instillate solution. Do you think that's something that people underappreciate the use of antiseptics? Is it something we need to educate people on?
So I think that the question may come down to which of those two types of agents, antiseptic versus antibiotics, are active against biofilm organisms. So when organisms are in biofilm, we know that they're metabolically tuned down so they don't respond to antibiotics the way they did, even if the antibiotics can get there. So originally we thought the problem was the antibiotics didn't make it to the organisms through the polysaccharide coating that causes the biofilm, but now we know that even if they get there, unless organisms are replicating, they're not susceptible to cell wall active antibiotics, for example. I think maybe there's a lot of things that could be going on. One could say that what you're doing is harming the cells that are trying to close the wound by your antiseptics, by the topical toxicity, as Alexander Fleming spoke about in 1919. It could be that what's most important is this flushing and cleaning of the wound that's going on, and saline is as good as doing that as other agents that have antibacterial activity. It may be that whatever you're putting in the wound is not actually very active against biofilm organisms, so it's acting like saline. It's no better than saline. I mean, one can make a number of postulates, but I think you're asking the right question. And I'm thrilled that you're doing this study, because that's the first question. If saline is as good as what we think is among the very few installates that is likely to work, because you have all this experience with it, and the experts in the field think that the product that you're using, the Prontosan, is one of only 3 that they would recommend, then I think what we're saying is that the flushing mechanism may be all that we need, and we don't need anything more than that.
On that note, we'll finish, and hopefully next year we'll have some randomized data to present. Thank you all very much.